This video will focus on persistent mental health disorders. The information has been provided by the Ontario Neurotrauma Foundation's Best Practice Guidelines for Concussions and Mild Traumatic Brain Injuries. Mental health disorders are common following a concussion or mild traumatic brain injury and have been found to be major determinants of post-injury wellness and recovery, examples of which include mood disorders that consist of symptoms related to both depression and anxiety. The cause of injury-related mood disorders may be related to environmental factors, such as the trauma resulting in the injury manifesting in post-traumatic stress symptoms or to the negative outcomes following the injury, for example, depression due to inability to participate fully in work or school-related activities. They may also manifest as a response to chronic symptoms following an injury, such as poor sleep or persistent headaches. It is often difficult to obtain timely assessments and treatment interventions from mental health experts. Delays can, and often do, contribute to worse outcomes, and so it is important that primary care providers intervene as soon as possible. Screening for mental health symptoms and determining their cause, as well as prescribing treatment, is crucial to facilitating a positive recovery. Currently, there is no evidence to indicate that mental health disorders of those who have suffered a concussion or mild traumatic brain injury should be treated differently than disorders that have occurred through other means. As such, pharmacological and non-pharmacological interventions, including therapeutic interventions that have been found to be helpful in the general population, should be considered for individuals who have developed mental health problems post-injury. Acute concussive symptoms can include irritability, anxiety, emotional lability, depressed mood, and apathy. Early education and treatment focused on symptom management is important. If symptoms persist, the risk of increasing symptom intensity is heightened, manifesting in more severe mental health symptoms such as major depressive disorder and post-traumatic stress disorder. The assessment of mental health disorders can be challenging given the overlap in symptoms between mood disorders, sleep disorders, pain syndromes, as well as cognitive difficulties. In general, it is recommended that the DSM-5 diagnostic criteria be applied in an inclusive manner, for example, counting all relevant symptoms toward a potential diagnosis of depression, regardless of whether the injury alone could have caused the symptom. There are various self-reporting questionnaires that can aid the clinician in assessing mental health disorders. These can be found in Appendices 8.1 through 8.5 linked below this video. Note that the questionnaires, however, have not been validated specifically with concussion and mild traumatic brain injury populations. It is also important to note that when assessing an individual, the healthcare practitioner should take a comprehensive history, perform a structured clinical interview, and observe behavior in addition to the use of the self-report questionnaires. Cognitive behavioral therapy and other psychotherapeutic modalities have been established as effective treatment of primary mood and anxiety disorders. There has since been emerging evidence of its effectiveness in patients suffering from post-concussive symptoms. Based on previous evidence, psychotherapy should be recommended for patients with persistent mood and anxiety issues following an injury as a non-pharmacological intervention. However, the decision to recommend psychological intervention will depend on factors such as patient preference and motivation, symptom severity and comorbidity, skills and experience of the treating clinician, and the ease of access to such resources. Medication may be required for those with moderate to severe persistent depressive or anxiety symptoms. However, the concussion and mild traumatic brain injury population may be more sensitive to adverse medication effects upon cognition, such as alertness, attention and memory, balance and dizziness, sleep and fatigue, and headaches. When prescribing any medication for patients who have sustained an injury, the following should be considered. Use caution when initiating pharmacologic interventions to minimize potential adverse effects on arousal, cognition, motivation, and motor coordination. Start at the lowest effective dose and titrate slowly upwards based on tolerability and clinical response. Allow adequate time and duration for drug trials. Avoid making more than one medication change at a time. Doing one thing at a time will enable more accurate assessment of drug benefits and potential adverse effects. Follow-up should occur at regular intervals, initially more frequently while increasing medication to monitor tolerability and efficacy. For more details regarding pharmacotherapy after an injury, refer to Table 8.1. An SSRI is generally recommended as the first-line pharmacological treatment for mood and anxiety syndromes after an injury. In some cases, however, the combination of sedative, analgesic, and headache prophylaxis effects from a tricyclic may be desirable, yet these agents may generally be considered second-line. Other second-line options include mirtazapine, an alternate SSRI, or an SNRI. For PTSD symptoms after a concussion or mild traumatic brain injury, SSRIs or SNRIs are typically recommended as first-line pharmacotherapy as both can improve the core symptom of re-experiencing hypoarousal and avoidance. After successful treatment with an antidepressant, maintenance treatment for at least 6 to 9 months is advised to reduce the risk of relapse. For further information regarding persistent mental health disorders, you can refer to Section 8 of the Ontario Neurotrauma Foundation's Guidelines for Concussions and Mild Traumatic Brain Injuries and Their Persistent Symptoms. Special acknowledgements go out to the Kinesiology Department at the University of Waterloo, the Centre for Community, Clinical and Applied Research, and the Ontario Neurotrauma Foundation, which provided the funding for this video.